Yes, Priyanka. Yeah.
Okay.
Sure. So, good evening, everyone. Good evening, all the faculty members, Dr. Sanjeev Jolly sir, Dr. Nagendra Rupati sir, Dr. Jimmy sir, Dr. Ajit Ghosh sir. So we will start this session with a short introduction about our holding company, which is Integris MedTech, and then we will hand it over to Dr. Nagendra Rupati sir to take it forward with the session coordination. Uh, I'll just share my screen. Just allow me a minute. Hope my screen is visible. Priyanka, can you confirm if my screen is visible?
Yes, it is.
Perfect. Uh, so, Translumina Therapeutics Limited is part of a holding company called Integris MedTech. So Integris MedTech is also the holding company of another leading lab analytical equipment organization called Everlife. So together with Everlife and Translumina combines to form the Integris MedTech brand. Uh, Integris MedTech has a very diversified portfolio with cardiovascular, with in vitro diagnostics, with the Everlife brand coming in. Coming to our market position, we are the leading player in scientific lab solutions in Southeast Asia. We are the second largest stents player in India. And overall, our market share in coronary stents in India is 18%. What this combination gives us is an unparalleled market access to more than 2,000 plus hospital and cath labs directly, 17,000 plus laboratories, and 350 plus distribution partners across 60 plus countries. We have a strong R&D and manufacturing across. We have 100 plus SKUs manufactured. We have 7 manufacturing centers in India and Europe, and 2 R&D centers. So this slide tells the different product portfolios segment-wise that we have. So in cardiovascular, we have polymer-free stents, we have advanced coronary DCB called Protege, we have calcium modification technologies for IVL, like IVL and OPN ultra high pressure balloons. We have IVers from Assist, and then we have a range of vascular accessories. With Everlife coming to us, we have now access to immunodiagnostics, clinical chemistry, hematology, molecular diagnostics, and other clinical diagnostic tools. Plus, we also have access to cell biology products, antibodies, genomics, proteomics, etc. Some of the in-house brands is what you can see. We have collaborated with the world famous brands like Sys Medical, Shockwave Medical, Kaneka, Assist, Asahi, and then other brands that we are going to acquire as part of this Everlife Asia. So coming to how we are shaped up in terms of Translumina. So we are the leading cardiovascular device company in this in India. We are second largest stent player with 18% market share. We have a global presence. We have a distributor network of 50 in 50 plus countries and a sales team of 20 plus members internationally. And we have a robust manufacturing core in India, Germany, and Netherlands. So with that, uh, this is the last slide, which talks about in different modality of coronary angioplasty. We have products related to access, we have products related to assess, we have products related to prepare, and then we have products related to treat. So starting from Asahi to Kaneka to Assist to preparing the lesion with Shockwave Medical and then Sys Medical OPN to treating the lesion with a range of fantastic stents. So with that, this is the end of the corporate deck. So I would now like to hand it over to Dr. Nagendra Bhupati sir to take this session forward. Over to you, sir.
Hi, everyone. Thank you for this opportunity. Thank you, Dr. Jolly, for being here. For the audience who are watching this seminar, Dr. Jolly is a great interventional cardiologist from the Mecca of evidence-based medicine, McMaster University. We have followed, as a student, I have followed Dr. Jolly's original research uh, from my fellowship days, starting from Topaz all the way to complete. And his McMaster team is everywhere, starting from prevention to intervention. Everywhere they have done path breaking and practice changing. That's the right word to mention. That's practice changing studies. Thank you, sir, for being here and enlightening us. In this particular agenda, the particular program, we will be discussing about OPN. Do we have a case presentation by the other speakers, Raunak?
Yes, sir. We have case
Yeah.
presentations
I
as
would
well.
suggest to start with the case presentation if Dr. Jolly agrees, so that we can go with my talk at the in between the session.
Sure, sir.
Yeah, that would be fine.
Oh, thank you, Dr. Jolly. Yeah. Let's move on to the first presentation by Dr. Arjit Ghosh. Or Dr. Arjit is there?
I'm there, but I was not asked to present any case.
Oh,
So can we move to the next speaker?
okay. Raunak, why don't you take over and go with your speakers of choice?
Sure, sir. Sure. Dr. Aftab Khan, sir, if you would like to share your presentation, sir.
Yeah, sure, not an issue. So I'll just use my share option. Just give me a minute. Yeah. Yeah. So is my slide visible there?
Yep.
Yeah.
Yeah.
Yeah. Yeah. Just give me a minute. I'll just webinize this. Okay. So I'll start off by presenting a few cases, and I think the focus of today's discussion is on the use of the OPN balloon. And I think this is a talk that was given to me to talk about the right pressure or the right size. Just a minute, I'm just trying to minimize my, I just seem to have lost my cursor somewhere. Oops, just a minute, yeah. Have I lost my presentation or is it still visible?
You need to reshare.
We could not see the presentation. We saw
Dr.
it.
Aftab, you need to reshare this slide.
Yeah, I'll just do that. I'll just do that.
Yeah.
Now you got able to see it?
Yes, if you can run it in presentation mode. Yeah.
Yeah. Okay, so I think the topic of my talk is right pressure or right size. And I think this is an important concept for all of us when we're treating our complex calcified lesions, because I think there's a balance that we need to decide to crack the lesion, at the same time not end up causing a perforation that could be life-threatening in many of our patients, especially the ones with complex coronary anatomy. So I think this is the talk which is going to focus on the use of an OPN NC balloon. And this is a great balloon that we've been using in our labs for quite some period of time. The best advantages of this balloon are that it's double layered. It goes up to a rated burst pressure of almost 35 atmospheres. It also has a safety profile in the sense that it's a non-compliant balloon and it grows by only around 10%. So the compliance chart is very good. So at every 10 atmospheres, it grows by only 10%. And you can go up to an atmosphere of 35% as the RBP that is recommended. But we have gone up to almost 45, 50 also. And we have a separate indiflator for that to make sure that you can go up to higher pressures. But usually it's at 32 to 35 atmospheres that most of the lesions that you want to crack would yield if you use it in an adequate sizing. So when it comes to perforation, I think we all have understood that it's an oversized balloon rather than a high pressure that causes most of the perforations. And therefore, the trick when you're using these balloons is to make sure that you undersize the balloon when you're using it for calcified lesions. And therefore, the trick would be to downsize by 0.5 millimeters when you're using it for de novo lesions. And if you're using it in stent for an ISR, for example, you could probably go it with 1:1 also and go up to higher pressures. Well, the sizing, usually it may be an eyeballing, but if you're doing a complex lesion, having an imaging by either an IVUS or an OCT makes it that much easier. for you to understand the morphology of the lesion, to understand the plaque distribution, to understand the calcium load, and to understand a debulking strategy. And of course, it also helps you to size your size of your balloon. But then it's not absolutely essential to use an imaging whenever using an open balloon. Again, as we talked earlier, the profile is such that it grows by only 10% by every 10 atmospheric pressure. And therefore, this is a safe balloon when you're doing your procedures. The other advantage is because it's double layered, it does not get a dog boning effect that you would see with your other non-compliant balloons. And therefore, the edge dissections are something that's not so common when you're using this balloon. We have the Victory trial. I think we'll be discussing about this, which has shown a non-inferiority of IVL as compared to of opium balloons as compared to an intravascular lithotripsy in patients with calcified lesions. So the tips and tricks when you're using an opium balloon in my lab would be, of course, to avoid a polymer sleeve wire. The reason is sometimes that it tends to stick onto the balloon, especially if you're going high pressures beyond 35 atmospheres, and then it tends to pull back the wire along with the balloon if you're pulling back the balloon after you've done an inflation. And therefore, we usually prefer non-polymer sleeve wires. And especially when you're doing complex cases where balloon support or your guide support and wire support are equally important, use of extra support guide wires like gland slams is especially essential to make sure that you can deliver your balloon and not pull back the wire when you're doing the procedure. Again, as we said, for pre-dilatation, it's usually downsizing by 0.5 millimeter less than the reference vessel diameter and going up higher pressures. You can use the same balloon for post-dilatation also, where you can then go 1:1 to the vessel size to make sure that you've done a complete apposition of the stent to the vessel wall. Slow increments of pressures are essential. So when you go higher than 20, you go slowly 5 atmospheres every 10 seconds or so to gain adequate luminal gain, and then allow the balloon to work. So it's not a quick inflation and quick deflation that you do with your other non-compliant balloons. You wait for some period of time so that the pressure builds up and it helps the lesion to crack. This is a small a series of cases. I think starting off with this elderly lady, hypertensive dyslipidemic CKD stage 3, presented with acute chest pain. A pharmacoinvasive approach was done, thrombolysis given elsewhere, and then transferred to my place. Had ongoing chest pain with an ST resolution, anti-reval changes with a GFR, a renal compromised creatinine of 1.6, GFR of 52. So this was the right coronary lesion. Again, you can see that there is a dominant vessel with a mid lesion, which is critical, along with another lesion in the distal part of the right coronary artery. But the culprit was this lesion in the LAD. And well, I'm not certain if you can see it angiographically. We can see that there's a Tromp-Track appearance, and I hope this shows it better. That's a critical lesion. It's a flowing artery, thanks to the pharmacoinvasive therapy that this lady has had, but she still has ongoing chest pain, and we decided to intervene at this period of time. These are the other setup shots. Again, you can see that the lesion is right from the proximal part of the right of the LAD, and it's quite calcific with a Tromp-Track appearance extending almost to the mid part. Choice of debulking, well, it could be high pressure balloons. Rotablation, we usually tend to avoid in patients who've had this thrombotic presentation, basically to avoid a slow flow. We could also have used an intravascular lithotripsy. Well, this was at the time when orbital atherectomy was not available in India. So this was a case which is almost, I think, 5 years back. And XSL laser was not something that we did in our case. So this is a patient we used a guide catheter, which was 7 French, and then went into the balloon. So this is a non-compliant balloon to start with, and you can see that the balloon just slips away. And that's something that will happen when the calcium is really very dense, and it tends to ping pong the balloon. And next we went in with our opium, and this was the opium balloon that was used to make sure that we could crack the lesion. Oh, sorry, this was not the opium. This is just the inflation, small non-compliant balloon to make space for the imaging catheter to go in. And this is an OCT that we did. And just to frame images, you can see that there's severe eccentric or concentric calcium all around in this critically stenosed proximal part of the left anterior descending artery. Well, based on the sizing, we decided to use an opium balloon to crack this lesion because it was a dense calcium all around. And this is the balloon that was being cracked. But again, I think we took a 3 millimeter opium balloon and went up to almost 35 atmospheres. And this is what happens. You can see that once we are inflating it, you can see that there is a perf that has happened even in an opium balloon, and that contrast sips back into the proximal part of the LAD. And there's also the shoot that we take thereafter, which shows that there is a little bit of a dissection flap thanks to the pinhole perf that has happened in the proximal LED. And a few shoots later, we realized that there's some perf that's extended downwards, downstream also. We just take a small balloon to attack the lesion. And again, this is a type 2 perforation that has happened. And again, after we've tacked it with a small balloon, we see that it's a contained dissection. Well, this is the Opian indiflator, and as I said, though the balloon has been rated as an RPP of 35, it gives you an indiflator that can allow you to go to almost 55 atmospheres also. This is a small bench testing that we did in our lab that time to show that when you use a non-compliant balloon and when you sort of blow up the balloon, what would happen is that when a non-compliant balloon bursts, it really causes a volcano effect, and you see that the entire artery can rupture. But vice versa, when you use an Opian balloon to crack this lesion, and when you go to a very high pressure, I'll just run through this, and when you go to a pressure of almost 50 atmospheres, you can see when the rupture happens, it's usually a contained rupture. And that's thanks to the double layer of the balloon layering that you have. So again, after this, we then went ahead with the stent and stented the artery, extending it right into the distal part of the left main also, since we had a dissection flap there. And this was the post dilatation again done with the non-compliant with the Opian balloon to get a good result, and a pot done there to tag the left main. So this is the final result that we had, and the lesion had been treated well. And this is the post IVUS imaging. And you can see that there's a little area of malapposition in the mid part. That's where we had over the bend when we had the small area of perf, which was then corrected by means of a semi-compliant balloon. And you get a good post-luminal area comparing to the previous pre-intervention lesion. So this is how it looked pre, and this is how the post result was in this elderly octogenarian with an acute coronary syndrome. Well, at a staged procedure, we then treated the right coronary artery. And as expected, the right coronary artery was also calcific, though it yielded well to a non-compliant balloon itself. And eventually it was treated with 2 stents to get a good result. Again, we have used Opian also for other times. And this is one case where it seemed like a simple right coronary lesion. And my fellows, they thought that we'll just tackle this lesion with a normal balloon and finish it off. Eventually, because of the fact that they felt that there was a plaque extended to the crux, a stent was placed right up to the crux of the right coronary artery, and we realized that the lesion had cracked, but the lesion ahead still showed a wasting with the stent. This was the non-compliant balloon which was tried to be used with no response, and then again we had to use an Opian balloon to crack the lesion. So this is how it looked after the Opian, and this is the one with a non-compliant balloon. And on the right panel, you can see this is the Opian balloon, which has had the lesion to the stent to be opened up to an adequate response. Opian has also been used as an adjunct to other debulking strategies. So this is a case where we had a left dominant circulation in an elderly man. Again, you can see that there's a huge chunk of calcium that's sitting at the mouth of both these osteoproximal LED as well as the circumflex. And there's another lesion in the mid part of the LED. So these are other views. And the setup view again shows the huge decalcified plaque. And I think this view on the right shows us the calcium load. Well, this is a gentleman who is clearly not very interested in surgical revascularization, and then we were left to treat him with a PCI. So again, for this patient who has a non-dominant right coronary artery, again, it's important that we do an imaging, and an imaging in this artery showed us that there was a huge amount of plaque burden, and we had imaged both the right coronary artery. Here, this patient, we used an imaging with IVUS. And again, in this patient, I think these images are long to play, but what we found is that there is a ring calcium all around at the left anterior descending artery ostium, and there is at the ostium of the circumflex also, there is a significant calcium burden. So here what we decided was to use the Opian balloon for the mid part. The only issue is that we had a 3.5 Opian, which we felt could probably not be able to tackle the osteoproximal part of the LED, because that was almost a 4 to 4.25 vessel. So therefore, what we decided is we made a small balloon inflation with the Opian there, but then we decided to go in with an intravascular lithotripsy, and we used a 4 IVL balloon both at the osteoproximal part of the LAD as well as into the circumflex. And then we followed up with the opium balloon again to crack the mid part of the lesion, and eventually used 2 stents. So again, you can see the dog boning effect in the cranial view. And after you used the opium balloon here, you can find that the dog boning has resolved to a certain extent. So this is post IVL. And again, I think we finished up with a mini crush technique. And eventually, this was the final result. Pretty encouraging. And the intravascular imaging also showed a pretty good result. And this gentleman has been on a follow-up with a good clinical response. So this is the final shoot, which shows a widely patent left system with both stents in the LAD and the circumflex. And these are the images post stenting. And you can see that in the proximal part of the LAD, we have achieved 11.5. And in the circumflex, we've achieved a 9+ vessel diameter. We have also used opium for extrinsic calcium as an adjunct to rotablation. And this is another gentleman who had a very calcified nodule in the proximal part of the mid part of the circumflex, which was not crossable with your imaging catheter. Also, we managed to get the wire down and then exchanged with a rota wire, and eventually ended up doing a rotablation for the mid part of the circumflex to tackle that nodular calcium there. This was the post-rota image, and we had to really debulk it or crack that lesion more post-rota because the imaging showed that the area gain was not adequate. So this was again the imaging catheter that went in, and here we used an opium balloon. Again, it was a little difficult to get the opium down, and therefore we had used a Guidezilla catheter to help us to track the opium balloon down. And this is after the lesion was cracked. And here you can see that the area that we got post-balloon was a 3.68. We had to stent this artery and finally post-dilated with an opium. So this was the final result. And here you can see that this was the result pre-opium after the stent implantation. And you can see there's an area of under expansion here, which after opium use can show that this artery has been, the stent has completely expanded and has reached our adequate desired level. So to conclude, severe calcium is present in a large majority of our patients here, especially as we face more challenging cases of octogenarian and patients with diabetes and renal failure. Proper plaque modification, calcium modification is essential to ensure an appropriate expansion. 2 common reasons for ISR is usually a stent under expansion or new atherosclerosis. And opium balloon is a great balloon for us to modify our calcium to make sure that we don't end up having these problems and give a good result to our patients in the long run. So I'll stop my share here and I'll be happy to discuss further.
Thank you, Dr. Aftab. Dr. Ghosh, would you like to have any questions?
Yeah. Sir, your first case, all the cases done by Dr. Khan was excellent, as it is usually done here. We are quite aware of his angioplasty acumen here in Kolkata. Sir, was the first case done before the victory trial, or it was a post-victory angioplasty? Because
no, this was, yeah. So I think this was almost 5 to 6 years ahead. I think this was when the time that we did not have IVL also in our labs. So this was quite some time back, and this is the time that we only had opium and we had the NC balloons, and we had the cutting balloons, of course. But I think would I have changed my strategy differently? Well, if I had IVL, it would have been a more expensive option. But yes, here we now know that IVL, I mean, with the victory trial, probably the approach that we did was nothing inferior to what we would have done earlier.
So your way of thinking 5 years back is currently endorsed by the victory trial, isn't it?
Yeah, but I think sometimes we have to deal with our patients with what we have in our labs. And I think for all of us, sometimes, yes, I understand many of these patients with calcific lesions are not ad hoc. We can always plan out these procedures, and that is what I would recommend for most of our fellows also. I think there's no need to rush without having all the equipment on the shelf. But then this was a patient with an acute coronary syndrome where we were forced to take in. So would I have treated it differently? The answer is probably no. But again, IVL sometimes makes it easier, and when you don't have to struggle so much. But again, I think this was a lesion that was pretty easy to access, not too many bends, and when you use a good supportive wire, I think an OPN can sometimes give an equally good result.
Thank you, sir.
Okay. If there are no other questions, let's move on to the
Dr.
talk
Bhupati, I
by-
think Dr. Jolly wanted to ask something.
Yep.
No, I mean, I think it's important that we kind of review both the shortcut trial results and the victory trial results. So I'll talk about that, in just a few moments. So, back to you.
Yep. Okay. Let's move on to the agenda by transluminal with the talk from Dr. Jimmy George. Dr. Jimmy George is a senior interventional cardiologist working in Lisi Hospital, Kochi, Kerala, India. Dr. Jimmy.
Thank you, Dr. Bhupati. I think I'll just share my slide. I'm sorry, I'm just traveling up, so I just hope it's visible and it's clear. So, am I audible?
Yes, sir, you're audible and we can see the screen
Thank
also, the
you.
slide set.
Sure. So, mine is a 74 years old gentleman who had a coronary event around 2 decades back. He was on aspirin, but details were not available. Now he had presented with an acute event. He had a fair LV function, and his angiogram had shown a double vessel disease. He had a distal circumflex involved, which they had undergone an angioplasty elsewhere. And now this LAD, which seems to be a calcified, almost a subtotal occlusion, was thought to be at least a 2 decades event, but still, after the stenting of the circumflex, the patient was still symptomatic. So hence, a angioplasty to the left-handed descending was planned. So this was attempted with an XTA 1 gram tip load wire, which unfortunately buckled up, could not cross the tight depletion. It was escalated to a Gaia 2, and a turnpike gold was used so that the calcium could be screwed better or manipulated better, the wire could cross better. As you can see over here in the cranial view, the wire is subintimal. There's a Gaia 2 wire which is gone subintimal because of the calcium deflection. Hence, it was again escalated to a Gaia 3 series. And you can see that the multiple deflections of the calcium, but with the help of microcatheter, slowly, you can see the drilling movements. And it seems to be now cross the lesion and in the true lumen. And you can see the microcatheter which is stuck over there, and it's not crossing after multiple attempts. Hence, the rotawire was parked through the microcatheter. Hopefully, fortunately, the microcatheter did not buckle back, and we could land the rotawire down. A 1.25 burr was started with slow speed, with almost 160,000 rotations, and slow burring for almost 3 to 4 minutes, gave way, and it crossed. The final polishing was done. And again, it was pre-dilated with multiple NC balloons, but still you can see a dark spotting effect right at the center of the lesion. And the imaging catheter could cross, and you can see the deep, thick calcium almost involving a 360-degree arc around the tightest area, A lot of fibrous tissue also, as well as deep, thick calcium over there. That's the dissections caused by the recurrent predilatations, as well as the atherectomy. The lumen area had almost come up to 3, but you can see the thick calcium of it, which definitely needs to be tackled up. Hence, an opium was used, and you can see the dog bonding effects slightly going up when the pressures were increased from 35 to 40 plus. Fortunately, no perforations occurred. This was followed by deployment of 3 to 48 drug-eluting stent, post-dilated, and there was a final OCT. Seems to be well expanded. That comes at that's the tightest area. Some prolapse, but there's no much of malapposition or stent deployment. Seems to be well expanded there too. So almost proximally got around a lumen area of 6 plus, and that was the final result. So I would like to conclude by saying that calcified CTOs are the more troublesome lesion. Stiffer wires and topical microcatheters are very necessary. Atherectomy, OPN, IVL adds to plaque modification. Larger lumen and better stent expansion is the key. Thank you.
It was a great case, Jimmy. So regarding your particular case, do you think an IVL could have also been helped rather than OPN? Let's forget about victory trial that will be presented by, or the shortcut that will be presented by Dr. Jolly. The way how the OPN, am I audible?
So the thing is like, actually the NC balloon had opened
The
up
way how
to
the
an extent.
OPN expanded, it was a little scary at the end. Though it was the waste was given up within maybe from 36 to 38 kind of atmosphere, just like that. It was actually looking scary.
Yeah, exactly. That's the problem with OPN or high pressure balloons. You need to go up with higher pressures, and that really increase your adrenaline too. So always it's safer to go with something with a 4 to 6 atmosphere, a low pressure IVL. But most of the cases I use IVL for a post-in dilatation, keeping in hand the calcium bootcamp. But here it was a 360-degree calcium. Those chances of perforations were less even if you go at high pressures. So when you have a less arc of almost 270 or 180 degree of calcium, you get a give way to the other area when you're using high pressure balloons. So that was my take. That's why upfront I took a OPN over an IVL here.
It was a 3O OPN, right?
Yeah,
It's
it was a
2.5.
3 OPN. It was a 3 OPN.
Okay.
The rota had crossed, the balloons were crossing up, so I thought I'll have to even open up proximally too. But finally, I
Okay.
ended up with a 3 stent. That's the only thing.
Yeah. That's
So
a great.
Bhupati, I have a question. This is
Yep.
Dr. Uriel Coach. So what is the recommended pressure that you can apply in an OPNNC balloon? I'm asking this because we often in the IFU we find that the recommended pressure is only 35. They do not recommend you to take the balloon even more up to an extent of 40 or 45. I had an experience of taking the balloon to 45 and having a contained perforation. So I was lucky that it was not a free perforation, and I managed it. But can I support my use of taking the balloon to 45 atmospheric pressure? Do you recommend to?
That's a great question, Dr. Arjit. From our experience, we have proposed a criteria how exactly it has to be used. Up to 20, you can go. After that, it has to be gone in every second. It has to be 2 or 8 ATMs. You can go up to IF. The target is to expand the balloon, not to reach the pressure. If sometimes, many times, there's no need to go to 35. It will reach. It will open up in 30 itself. So if you are not able to open up 35, then if you intend to go more than 35, then I would strongly recommend whatever the size of OPN, you have to have imaging done before selecting the balloon size, number one. What Dr. Jimmy did is the right thing. Number two, the highest pressure that I have gone is 56. So it doesn't mean that every patient I will go. That is a chance. So whenever I go more than 35, irrespective of anything, I ensure that I have a guideliner, 7 French guideliner, and I have an appropriate cover size sense. Many times your 6 French guideliner will not allow you to take a 3.5 cover sense. So all these things has to be kept ready before escalating your pressures from 35 to 45. If there's any something is not there, I would never take a OPN 3O OPN without doing imaging. These are all the proposed criteria. What I have, what the SOPs kind of thing, what we have in our lab. That is, if the OPN is more than 3, definitely imaging. If you intend to go more than 35, then definitely image. These are all the situations where imaging is very mandatory. As such, we should have a very low threshold to do imaging when you consider using OPN. That's my thought process.
I would agree with that, and I think it's important to know that as you go beyond 35 atmospheres, likely that balloon will grow more. So undersizing it, particularly if you're going to go to 40, 45 atmospheres, is critically important.
It was an instant restenosis. So it was an unyielding sort of lesion. Even at 35, I was not being able to crack the lesion. So I was forced to take the balloon to 45, and I landed up in a contained perforation.
Yeah, sometimes these things happen. We cannot compare the complications that we can have with OPN balloon with regular NC balloons, because these balloons are used only in tough situations. So complication will definitely be, it has to be compared with other subset of complex adjunctive equipments like rotablations or orbiters rather than with the regular NC balloon. For want of time, let's move on to the next presentation by Dr. Jolly. I would like to have a short introduction of Dr. Jolly. Dr. Jolly is a a professor of medicine from McMaster University. Starting from his initial studies like total, starting from rival, the transradial studies and then entering to total. And then last year he had a couple of publications in NEGM, clear synergy. All our path-breaking, practice-changing studies. I request Dr. Jolly to provide more insights on victory and shortcut studies that have been presented in the recently concluded TCT 2025.
Thanks so much. It's my pleasure to be here. And I'm going to be talking about both the victory and shortcut trials that were presented at TCT. These are my disclosures. I think one of the important things is we know that calcified lesions, as we've shown here, have high event rates. They have higher perforations and complication rates, and we have little randomized data on this. The ECLIPSE trial was probably one of the most important trials in this area because they showed that NC balloons were actually safer than a strategy of routine orbital atherectomy. Really, if you look at the IVL trials, most of those FDA approval trials were single arm with no control groups. So we really need randomized trials with IVL versus other therapies such as the OPNNC. So there is sorry, let me go back here. There was a registry performed with Lucerne as well as Hamilton, about 50 cases. Actually, Natalia Panil at our place ran the OCT core lab. And in patients with heavily calcified lesions, the OPN worked quite well, with mean final expansion of about 85%. And there was actually no perforations in this registry. So this is really the first step that maybe this is a reasonable option. Maybe it can be tested against IVL. So the victory trial was designed as a randomized trial comparing the OPNNC versus IVL in patients undergoing OCT-guided PCI with the primary outcome of final stent expansion. The inclusion criteria were fairly standard criteria. So you had to have either angiographic grade 3 calcium with radiopathic densities on either side, but actually all patients had OCT. So the definition for OCT were at least an arc of 207 degrees of calcium. So as is recommended by CIS Medical, we undersized the OPNNC by 0.5 millimeter less than the actual vessel diameter. and the IVL diameter was 1:1, as is recommended by Shockwave. So these patients had OCT as the primary outcome, looking at stent expansion, and we had an OCT core lab which was blinded to allocation that actually did all these measurements at McMaster University. So this is the core lab findings. I think one of the important things is that severe calcification angiographically was about 60% of patients, and eccentric calcium was there in about 40% of patients. And that's important because, it's often taught that OPN works well in concentric calcium, but doesn't work well in eccentric calcium. Nodular patients, about 27 to 25%. One of the important messages here is that procedure time, they're trended to be lower with the OPNNC. You don't have to do 120 pulses as you do with IVL. It's usually a quick inflation. So approximately 9 minutes faster. And with the IVL, you tend to use more non-compliant balloons, as you might expect. Rotational atherectomy was not different, somewhere between 12 and 15% in both groups. The mean maximum pressure in the OPNNC group was 40 atmospheres versus 6 in the IVL group. The primary outcome of stent expansion was not different between the two groups, and was 85% in the OPNNC group and 84% in the IVL, meeting the criteria for non-inferiority. Irrespective of which subgroup you looked at, the results were consistent, whether they had severe calcification, whether they had a greater arc, whether the thickness was greater than 0.5, whether they had nodular calcification. And when you looked at strategy success, they were not different. Final stent expansion, above 80% as a proportion, was not different. When you looked at a minimal stent area, MSA, which is oftentimes is really one of the most important things, was not different. 6.3 versus 6.5 millimeters squared. And we look at clinical outcomes, so CV death, target vessel MI, or target vessel revascularization, they were not different. Now, one of the important things is there's always a concern with the OPNNC in perforations, particularly if you're going with a balloon up to 35, 40 atmospheres. And when you looked at the rate of perforations, they were not different. And there were no rates of cardiac tamponade within the trial. In addition, the individual components, such as paraprocedural MI, was not different. Target vessel revascularization was not different. And overall MACE was not different. So in conclusion, in severely calcified coronary lesions, the OPNNC was found to be non-inferior to IVL in terms of stent expansion and had a similar safety profile. And I think one of the more important things is that this is a reasonable lower cost alternative to IVL and actually may be faster to use. But the caveat is these patients all had imaging prior to the use of the device. And I think that enables you to size appropriately and use it safely. We're going to transition to the shortcut trial. This was presented at TCT as well. And this is a randomized trial comparing Shockwave versus cutting balloon. So this is the design. So patients really had the ability to have rotational atherectomy, and the randomization was stratified by the intent to perform rotational atherectomy. Patients were then randomized in a 1-to-1 fashion to either cutting balloon or IVL. And the primary outcome was post-procedural minimal stent area. Very similar inclusion criteria as shown here in terms of both angiographic and IVUS. They did not use OCT in terms of the angiographic criteria. And what's interesting, so, they specifically, very similar to the OPNNC or Victory trial, they recommended going to 0.5 millimeters smaller than the reference vessel diameter. And they recommended going to high pressure inflation with the cutting balloon. And this is an important point because, years ago, they used to say that, do not go beyond, 8, 10, 12 atmospheres of the cutting balloon. In this trial, they routinely went between 16 and 20 atmospheres, but they undersized it because those cutting balloons can grow as well. The primary outcome was shown here. Post-procedural minimal stent area was not different overall. 8.6 versus 8.0. P-value for non-inferiority is 0.007. However, there is a wrinkle here. Is that there was a significant interaction by the use of atherectomy, p-value of 0.004. What does that mean? Let me show you. So in patients who did not have atherectomy, in fact, cutting balloons didn't do quite as well as IVL. The p-value for non-inferiority is 0.339. So in fact, IVL had a bigger minimal stent area at 8.8 versus 7.7. And when you look at MSA within the entire stent, not just over that worst area, it was 7.2 versus 6.5, and was statistically significant. So the message here is that if you don't do atherectomy, in fact, cutting balloon may not be enough in these lesions. And this just looks at the other, the percent stent expansion, evidence of calcium fractures, which can be more difficult to see on IVUS. So in conclusion, when atherectomy is used, cutting balloon was not non-inferior to IVL, so when atherectomy is used, cutting balloon was non-inferior. However, when atherectomy was not used, the MSA was lower with cutting balloon than IVL. And I think we've all experienced this, that when you ROTA, you know what, oftentimes you don't need IVL. But if you don't ROTA, cutting balloon may not be enough in terms of modifying that calcium. So in summary, based on the TCT results, the OPN is a reasonable low-cost alternative to IVL, irrespective of atherectomy use. We actually did some analyses after the fact looking at atherectomy. It had no impact on OPN. But the cutting balloon may not be as effective as IVL, particularly without atherectomy. Thank you.
That was a great talk, Dr. Jolly. So do you think it's right time to change the calcium modification algorithm after victory and shortcut?
So, if you look at some of the consensus guidelines, such as the SKY consensus document on calcium modification, they are agnostic to some degree on the type of calcium modification. So what they say is that if they generally say, okay, you have a calcified lesion, you should image. If you can't cross with an imaging catheter or a balloon, then you should probably do rotational atherectomy. So use atherectomy. If you can cross with an imaging catheter and you meet the definition of high calcium burden, so depending on which rule you use, rule of fives, rule of threes, both deep calcium, nodular calcium, and an arc of more than 270, then you're supposed to use calcium modification. Now, they don't specify which calcium modification you should, they just give you a list. And I think, at this point in time, our approach is generally to use one of either IVL or OPN if you can cross. And we have tended to use it more OPN in concentric calcium and more IVL when it's eccentric. But the data in Victory actually suggests that OPN is a reasonable option in both areas. So I think this gives you both options. We didn't show that OPN was better than IVL, but I think the idea that a cutting balloon is enough without atherectomy, I think, is probably no longer.
Okay, that is great. Do you have any other questions, Dr. Ghosh, to ask Dr. Jolly?
Yeah, Dr. Jolly, three groups of lesions were left out. One is the calcified instant restenosis, and the other
Correct.
is osteal diseases were left in the Victory trial. So what was the rationale behind leaving osteal lesions in the Victory trial?
Yeah, I mean, I think that is a good question. I believe my understanding is that there was a concern that those may be particular lesions that may not respond well to OPN. But, and ISR as well is, we thought that was a different population. It's interesting, ISR is off-label for IVL. In my experience is, in fact, OPN can do a better job oftentimes than IVL post-stent. But I think that was this trial was designed before I came on board, and the leadership made that decision in terms of osteo lesions, I would have personally included them.
And how do you analyze the shortcut trial and the rotacut trial together? If we pool these two data together, do you have anything to say regarding calcium modification?
Yeah, I mean, I think rotational atherectomy is an effective form of calcium modification, and I think we know that. What I would say is that when you image, you can see the wire bias and where the rotabearer will come into contact with the calcium. So if you have a tight lesion and there's a lot of contact, you're probably going to get a fair bit of calcium modification with rota. If you have a big vessel and the lesion is not that tight and you have deep calcium, that's where rota is relatively ineffective.
Dr. Arjit, regarding your question of rota cut and shortcut, I think from both the study, what I infer is if you use rotablation, it doesn't matter whether you use NC balloon, whether you use cutting balloon, whether you use IVL. You will end up having almost nearly a equivalent minimal stent area. So I would say combining these two studies, I think rotablation is the winner.
Yeah, rotablation is the winner. Yeah, rota is the only deciding factor regarding the usage of the future balloon technologies, isn't it?
Well, yes and no. I think the rotational atherectomy use is dropping in parts of the world because of the introduction of IVL. And what we don't know from is that there are there may be higher rates of no reflow, slow flow with rotational atherectomy routinely. So there's still ongoing studies looking at rota versus IVL. And I think what Eclipse told you is that at least orbital atherectomy was inferior to an NC balloon for safety. So I think you get better. If you do rota, you can modify the calcium. What we don't know in a large study like Eclipse is whether the safety profile of rota routinely in every case is as good as IVL.
Dr. Jolly, I have a different questions for you, which may not be related to this particular topic. So regarding your practice changing studies, except rival, where you confer that radial definitely helps, you knocked out us by telling that. Am I audible? You knocked out
You
us
are,
by
yeah.
telling that there is use of thrombosection. You knocked out us by telling that there is no use of giving colchicine in acute MI. I mean, it's a kind of knocking on our head and telling that no, whatever you have been practicing is not good. So how exactly? I mean, even now, I know many people across the world do thrombosections. If it
Right.
is going to be a refractory thing, or if we don't see the distal vessels, do you still practice thrombosection in your procedures, or you are completely a no guy? No, I will not do that.
I think the message here is that it's used more selectively in our clinical practice. And this idea that you need to put down a thrombectomy catheter for every STEMI, I think is a false one. We probably use it in 10 or 15% of our cases. And I think the other important thing is that, there are newer devices. I don't know if you have Penumbra in India, but that may be more effective and that need to be tested in future randomized trials. So, the export is maybe not as effective as some of the more active catheters such as the Penumbra. We need to, if I have a huge thrombus burden, I often won't take an export. I'll take a Penumbra and try to do a more complete job from that perspective. And that needs to be tested in randomized trials showing benefit. And I think this is what, as a scientist, we have a hypothesis, we test it, and then we keep on trying to improve medicine so we can get better technologies, better medicines.
Okay, great. Dr. Ajit, do you have any other questions for Dr. Jolly? Am I audible?
You are audible. Yeah.
Yeah. May I go with my talk, Dr. Jolly?
Sure. Go ahead.
Okay. Is my screen visible?
Yes, sir, visible. You can put
Okay.
on the presentation mode.
1 second, 1 second. I'm just trying to. Where is that? Give me a minute. I think it has gone inside. I will add it now. Where is that? Oh. Yeah, I got it. Can you see my slides now? Am I audible? And can you see my slides now?
Yes, 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 doctor.
Okay. Thank you
Slides
for
are
this
visible.
opportunity to
Yeah.
answer my team. This is about a small study what we conducted in our center. Let me go back to. There's no need to talk about OPN in this for this August forum. We all know about the functionality, the anatomy and physiology of this particular balloon. In 2018, when I have to give the credit to Dr. Florim Kukuli, who came on a visit to India, and he told how exactly we should use this particular balloon. Since then, it's one of our go-to our equipment in our shelf. So we published our small data on the use of OPN in a couple of years before in a CRM, where we studied the efficacy of OPN balloon in patients with severely calcified lesion, and it's a single arm study and assess the safety and efficacy of the same. We nearly studied 93 lesions, and this is one important figure from this particular study. You can appreciate the minimum lumen area is 4.92 here after dilating with a 3.5 NC in this particular patient who had an ISR calcified lesion. After 3O and OPN going up to 40s, ATM, the area is 6.88. So it is again concluding that it is the pressure that matters. It is not the size that matters. So with this with this idea of using OPN in patient with severely calcified coronary artery disease, we went on and studied our experience with ISR patients. So we all know the challenges associated with ISR patients. So for what of time, I'm just skipping this particular slides about ISR. There are a couple of methodologies to how we can address such lesions that include balloon-based and non-balloon-based technology. So the study, principally why we conducted the study is to assess the safety and efficacy of using OPN in patients with ISR and documenting all the efficacy by means of imaging. It's an intracoronary IVS-based study. It's an investigator-initiated study. It was conducted prospectively from January 2021 to 2024 in single center study. We collected the data from our databases too. So OPN balloon, again, a high pressure dual core technology balloon, varies from 1.5 to 0.5 millimeter increment later on. The length varies from 10 millimeter to 20 atmospheres. The RBP is 35 ATM. However, it is proposed that each balloon is tested for 40 ATMs in the factory settings. The primary outcome in our particular study in ISR group is image-based success criteria, which is defined as a successful expansion of the stent by means of minimal stent area more than 5.5. Or if it is not achieved, then we should have achieved a minimal stent area of more than 90% of the distal reference area. If this is not achieved, then the minimal stent area by vessel area should be more than 39%. That is the residual plaque burden. This particular small sized vessel is going to be less than 39 or 40% based on ADAPT-DS data. So with this proposed data, there should not be any complication to tell that the patient has got a successful procedure. The secondary outcomes include follow-up data other than in-hospital mortality, myocardial infarction, repeat revascularization. All patients received DAPT for 12 months based on aspirin or based on the regimen of choice for the physicians, aspirin clopidogrel, aspirin ticagrelor in some patients. So we studied only 30 patients who has got 43 lesions actually. Predominant 1 in 4 out of these patients were only females. The median age is 67 years. Majority of the patients, every fourth patient, 4 out of 5 patients were diabetic, and 2 out of 3 patients were hypertensive. CKD by definition, EGFR less than 60 millimeter per minute was observed in 1 in 5 patients. LV dysfunction of less than 45%, that is moderate LV dysfunction or severe, were observed nearly in half of the patients. The clinical presentations predominantly is chronic coronary syndrome, other than NSTEMI and unstable angina. Lesion distribution, we had 49 lesions. Majority of them were located in LAD. Other than that, RCA and circumflex, and only one patient had a lesion in left main. We classified the lesion based on imaging criteria to identify what is the most common etiology of ISR in patients. We found that it's 1A is the most common etiology of ISR, under expansion related is the most common etiology of ISR in our patient category. This is what I was example of one such patient. You can appreciate kind of under expanded stent here, and after dilating with the opium balloon, we got a good luminal area. Sorry about this. Yeah. Okay. So here's one case example of one case example which I would like to show is a elderly male had an anterior MI who had a primary PCI from left main to middle AD with a couple of DES. After that, he had unstable angina. CAG showed, coronary angiography showed ISR to left main LAD stent, and proximal RC has got 70 to 80% lesion. He had a non-viable territory at that point of time, so the operator decided to intervene only the RCA with a 4.530 DES and a 4.522 DES in February 2023. This time he had a recurrent non-ST elevation MI with cardiogenic shock, pulmonary edema with moderate MR. The LAD to left main stent was patent, which was done before. However, the territory is completely non-viable, and he's got ejection fraction of only 20%. Current angiography revealed an ISR of 95%. This is the angiography of the particular patient. He was having recurrent NSVTs. LV function is only 15 to 20%. We did a cath, or a severe PAH. So we did an impella for this particular patient, and we used a groin approach to wire this lesion. You can appreciate the RCA stent, which is completely coming into the coming inside the aorta. Almost, I would say, it's at least 9 to 10 millimeters inside the aorta. So we could not negotiate through the stent. So we have gone through the basal portion of the stent, wired it, and serially dilated it. And after that, we did an imaging, which showed a significant under expansion, and we have definitely gone through the side portion of the stent. Now after that, we serially dilated it, and then took a 4O10 opium balloon and crushed the stent from the down, so that the crushed portion goes upside. Only the RCA ostium is covered by the stent. The rest of the crushed portion has been taken out of the aortic valve. I hope you can understand what I'm trying to say. The crushed portion of the stent is seen above this particular portion of the. You can appreciate the crushed portion there, which is hanging near in the lateral outer curvature of the aorta. So following which we discussed about doing a DES versus DCB. We again took a 4.5 NC balloon and dilated it. It's a huge vessel. It was not. We don't have a. We actually a 5O vessel. We don't have a 5O coronary drug coated balloon. So we need to swap the wire to a longer wire, and then took a 5O 120 millimeter peripheral balloon. It's an off-label indication, and took this balloon into the coronary. Most of the balloons are partially inflated inside the aorta, and then we finished the PCA with this particular result. Patient did well actually till a couple of months before. It was done in 2023. He had been diagnosed to have a glioblastoma multiforme. He's currently on radiation therapy. So this another patient, a 76-year-old male who had a non-ST elevation MI when he went to United States. A hybrid approach revascularization was done in 2022 for him. A lima to LAD was placed, and an IVS assisted PCA to left main to circumflex was done using a DES in 2022. This time he presented to us with the non-ST elevation MI with a moderate systolic dysfunction. The angiography showed a clear-cut ISR of left main circumflex stent. The RCA has got 90% lesion. The diffuse disease vessel. This is the ISR of the particular patient. The densely calcified vessel is not a stent actually. It's a vessel. Lima is patent. Sorry, it's not running. So again, we prepared the lesion. We did IVUS. We prepared the lesion very well. After that, we did again a good OPN balloon dilatation to open the particular stent at the circumflex ostium, which is the Achilles heel for coronary interventions. You can appreciate the densely calcified vessel all the way from down. You can appreciate the nodule here. This is the reason for this particular patients coming back again with ISR. However, after dilatation with the OPN balloon, the luminal area was quite good. Then we did not go for a second stent here. Again, an off-label indication. We were comfortable using drug-coated balloon. So after preparing the lesion very well with OPN balloon, we took a 3.5 OPN. I would have taken a 4 OPN, but it was not available on shelf on that day. Hence, we took a 3.5 OPN and went up to 58 MCA. Got a reasonably expanded stent this time with the confirmed with the IVUS. I usually target only 75%, maximum of 80% expansion at the site of nodule. I've burned my fingers when I target more than 90% of the site of nodules. Sometimes good result is, good result is enemy of excellent result is enemy of good results. So I would say 75 to 80% luminal area is at the site of nodule is good enough to accept. And then we proceed again. This patient also we need a 5O peripheral balloon. We ended up doing a 5O. Sorry about that. We ended up doing a 5O peripheral balloon, a DCB to this particular patient again from groin, radial side. 2 wires have been placed to get the support, and then it was done in the month of February 2023. He's doing fine as of now. No recurrence of symptoms. His LDL was 120s. We reduced it to 32 to 38 now. He's doing fine. So this our particular paper of using OPN in patient with instant restenosis has been published in Scientific Reports Nature. Thank you for your patient listening. Appreciate it.
Wonderful
Yes, sir.
presentation. Great talk. And I think the novel use of the peripheral drug-coated balloons, I think it was quite good to see, and obviously difficult to deliver. I think these is very valuable. And I think honestly, the more data we can have in terms of safety with the OPNC with registries is really quite valuable.
Thank you, sir.
I need to step off for another meeting, but
Sure.
I've really enjoyed this particular this presentation, and I've really enjoyed being part of this OPN colloquium.
Thank you,
I
sir.
must congratulate Dr. Bhupati for his excellent study. So it was an eye-opener for us that how an OPNNC can be used for underexpanded stents to give very good results. We often have a notion that in this scenarios, we got to address the whole thing with cutting balloons, but it is definitely an eye-opener for us. One question to Dr. Bhupati, if you find in your series the most common cause of instant restenosis. Am I audible, Dr. Bhupati? Yeah.
Yes,
So
sir.
So in
the
your
type
study,
1A ISR, it's under expansion.
yeah, it was an underexpanded stent. So do you have a gut feeling that for all varieties of ISR, especially when there is an proliferation of the neointima, IVL balloon is going to work equally well. The OPNNC is going to work equally well, and
I will not be surprised. I will not be surprised if there is going to be Victory 2 that randomizes patients with ISR to IVL or any other balloon to OPN. OPN will come out with flying colors, at least non-inferior.
So we can use OPNNC balloon across all the spectrums of instant restenosis. So this is your gut feeling.
I've got a specific set of criteria to select OPN balloon for pre-dilatation. I classify their use as pre-dilatation use and post-dilatation use. If it is going to be pre-dilatation use, definitely I take a balloon which is at least 0.5 millimeters smaller than the vessel size or the stent size. If it is for post-dilatation use, people say you can take 1:1. I don't recommend that. I take 0.25 millimeters smaller than the recommended stent size or the vessel size. Unless unless the stent is in a very straight segment, kind of a non-tortuous segment. You can take 1:1 there. Otherwise, 0.5 millimeter smaller for pre-dilatation and 0.25 to 1:1 ratio for post-dilatation. The pressure, the mean pressure that we have gone in both the studies are nearly 36 millimeter in pre-dilatation and 38 to 40 millimeter in post-dilatation. The ratio of the OPN balloon to stent size is slightly bigger, as I told, because we use a smaller balloon in pre-dilatation, both in native vessel group and in so I mean, post-dilatation, when you use OPN for post-dilatation, we are using a balloon which is 0.25 millimeter or 1:1. We tend to go to higher pressure. And definitely imaging is mandatory whenever I use OPN, whether it's for pre-dilatation or for post-dilatation. If it is not available, then I would strongly suggest to use it when you take a balloon which is more than 3 millimeter, or if you intend to go more than 35 millimeter.
Dr. Bhupati, in your study, was all the ISR image guided?
Sorry, sir?
So all the ISR angioplasties were image guided? 100% image
Yes,
guided?
sir. It's 100% image guided. Our first study was not 100% image guided. That is OPN in native vessel, but the ISR is completely image guided. The stents these days are so good, and we are good enough to postulate these days. You see that we studied these 30 patients, that is 49 lesions over a period of 2.5 years. It's quite rare to get ISR these days.
Thanks again for your excellent presentation. So we are really proud to have data from our part of the world.
Thank you, sir.
Yeah. Thank you, Dr. Arijit and Dr. Bhupati. Thank you for joining for today and for your valuable insights. Yeah. Thank you and good evening. I think our discussions are
Thank
closed,
you.
right? Yeah.
Yeah, with this we'll conclude this meeting. Thank you, Dr. Ghosh. Thank you,
Yeah,
Transhumanity. Appreciate it.